Good morning. I would like to start today with the classification of spine fractures, answering the question if they could be helpful for decision making. Okay, it doesn't work. Can you start me with another problem? During the last 2 decades, an increase of spinal injuries could be observed. This increase is primarily marked by a social change in more physical activity and the demographic development with a significant increase in older people. Considering only the relevant spinal injuries in Germany, the incidence is estimated to be about 10,000 new cases per year. The total number of spinal injuries, including minor injuries, should be significantly higher. 75% of all spinal injuries are motor injuries, while 25% occur in context of movement trauma. With regard to the age and gender distribution, there is a clear peak aged at 2040 with a preponderance of injury in men, which is about 60%. Parallel to the demographic development, there is an increase in frequency of spinal injuries in people aged over 65. Of all vertebral fractures, the majority occur in the thoracolumbar spine. More than half of all fractures concern the thoracic and the first lumbar vertebra. This results from specific biomechanical factors that arise in this area, by the mechanical transition zone between rigid thoracic and more mobile lumbar spine. Lumbar spine is more prone to injury because of the absence of ribs, transition from kyphotic to lordotic posture, and executally oriented chest joints. As causes of accidents, especially traffic accidents, followed by falls from a greater height and sports injury are observed in Germany. All patients usually fall from below high or an accident at low speed to suffer a fracture. In deciding the therapeutic approach, in particular, 3 issues need to be considered. First, does the patient have neurologic failure? Second, is the fracture stable or unstable? And third, how is nature and extent of the deformity? In a leg patient, it's easy to identify neurologic deficits by precise examination and to quantify them by established scoring systems like ASIOM or Frankenstein. But in a multiple injured patient who is intubated and narcotic, it might be difficult, and often the question of an initial neurologic deficit remains unclear. In this case, the need of an immediate surgical treatment depends on fracture morphology and the initial deformity. For this purpose, an accurate imaging is required. And polytrauma patient receives a complete CT with contrast medium from head to pelvis. For any diagnosis of intracranial, thoracic, or abdominal injury, simultaneous imaging of the whole spine and pelvis. In other cases, an X-ray in the anterior, posterior, and lateral view, and sometimes special images like open mouth view or oblique images could be necessary. Fracture and extension views are needed to exclude distal disruption. Magnetic resonance imaging has the element of damage or bone fracture remain unclear. There are a lot of classification systems, most of them for the upper cervical spine, because the osteoligamentous complex to protect the arterial spine is anatomically and functionally distinct from those of the subaxial spine. However, the most cervical spine fractures occur in the subaxial spine. That's why I will focus on established classification systems of these regions. Most classification systems are based on the thoracospinal based on the three-column concept devised by Dennis. Proposed by Francis Dennis, three-column concept divides the spinal segment into three parts: the anterior, the middle, and the posterior column. The anterior column comprises the anterior longitudinal ligament, the anterior half of the vertebral body, disc, and annulus. The middle column comprises the posterior half of the vertebral body, disc, and annulus, and the posterior longitudinal ligament, while the posterior column comprises the facet joints and articular processes, ligamentum flavum, and vertebral arch and interconnecting ligaments. Dennis based this classification on results of biomechanical studies demonstrating that an isolated rupture of posterior ligamentous complex is insufficient to create instability. An injury to middle column is necessary and sufficient to create instability. Only if the last two columns are affected, an injury could be unstable. Dennis used this model as basis of his classification system of spinal fractures. Each column has different contributions to stability, and their damages may affect stability differently. Generally, if two or more of these columns are damaged, the spine could be unstable. However, it depends on the characteristics of the fracture. In his original article, Dennis differentiated 5 types of fractures, A to E. This, the shown classification, is a modified classification. Type A and Type C fractures from the original article are summarized as Type A fractures. Type A fracture is a fracture of both end plates with an intact middle column. An actual force and flexion leads to collapse of the anterior vertebral body. The height of the posterior vertebral body remains uninvolved. It's important to note that chronized kyphosis more than 15 to 20 degree indicates an injury of another column, a burst fracture or luxation. The posterior column might be distracted. A type B fracture is a fracture of the end plate with an injury of the anterior and the middle column. Possibly retropulsion of bony fragments predispose patients to increased risk from neurologic injury. The predilection site is the thoracomotor junction. In type C fractures, the anterior column is intact, but the posterior and the middle column suffer from destruction caused by fast deceleration. In this fracture type, no particular site pattern could be identified. Damage could be only osseous, called chance fracture, or combined osseous and ligamentous. 1 or 2 segments could be involved. And type D is a luxation fracture. In this unstable fracture type, all columns are injured. The luxation is caused by either flexion and rotation with a fracture of the clavicular split in the vertebral body or by transversal shifting. The posterior-anterior type is often accompanied by a fracture of the posterior arc, but an anterior-posterior shifting might result in a complete disruption of the ligaments without a fracture. The model classification established in 1994 produced also the load and the typical pattern of injuries and is usually used in practice today. It's also based on the classification of Dennis and related to the RO classification. It relies on CT findings. There are 3 main groups depending on the load direction. 1 distinguished. Type A fractures caused by compression load, Type B injuries caused by distraction force, and Type C with rotation accompaniment. Compression injuries affects marked column, most commonly anterior, and often stable. The cause of the displacement injury could be either a fracture or extending. In type B fractures, two columns are damaged, and in rotation injuries, all columns are affected. From type A to C, increasing stability and risk from neurologic injury. Each of these main groups is further divided into three subgroups. For an inside classification, there is a third and sometimes even a fourth division. The classification in total is therefore very complex. I would like to show you the most common fracture type of each group. The most common fracture type is marked by bigger lettering. Type A compression fractures could impress as an impression of the end plates, as split fractures or as burst fractures. Characteristic of an A1 fracture is the impact dorsal vertebral body. In an A.3 fracture, there must be an intact dorsal ligamentous complex, otherwise it's a B fracture. Type B distraction injuries could be either transligamentous or transosseous flexion distraction injuries. Another mechanism is an hyperextended shear injury. In flexion distraction injuries with simultaneous compression of the vertebral body, the degree of instability against axial stress depends on the resulting deformity. If in type A passes on a type B fracture, it depends on the typhoid end. Type C rotation injuries. Rotation injuries could appear in combination with a type A or type B fracture, group C1 and C2, or with transverse shifting as shown in subgroup type C.3. These are the most unstable fractures. All longitudinal ligaments and often the disc are disrupted. Nearly 55% of patients with neurologic deficits. The frequencies of injuries of the thoracolumbar transition is shown in this illustration. As you can see, the most common fracture types are the A.3, B1, B2, and C1 fractures. As already said, the stability of fractures, especially in some compression fractures, depends on the extent of deformity. A fracture is believed to be stable if the X angle is less than 50 to 10 degrees or the height of the anterior wall, named A, is more than 2/3 of the height of the posterior wall, named B. A cup angle higher than 20 degrees or collapse of the anterior wall is a sign for an injury of the posterior ligamentous complex. A burst fracture with an involvement of the facet joint or pedicle is often unstable. Bilateral pedicle fractures are always unstable. A transitional displacement is a sure sign of instability. What are the main aims of any treatment? The prevention or amelioration of neurological damage, the preservation or return to stability, and the prevention of fracture-associated deformity. Conservative treatment is favored in stable fractures without neurologic failure. After a stress view, a standing position excluded an increase in deformity under axial load. These are mainly the type A1 and A2 fractures. The X-ray shows a typically A1 fracture in a young man which is treated conservatively. The non-operative treatment contains insufficient analgesia and an early functional mobilization. Radiological monitoring after mobilization after 2 to 4 weeks and a half year later is necessary, while back brace is needed only in some cases. But every fracture leads to an increase of mobility in the affected segment. Only if you degree, but enough to overextend the contiguous segments and cause additional pain. Then an operative treatment could be a therapeutic option even in stable fractures. Indications for operative treatment could be divided in ambulatory options and relative indications. Surgical treatment should be aimed at fractures with neurologic failure, unstable fractures, such as A3, B, and C fractures, and in presence of relevant deformity. An operative treatment treatment should be considered in pronounced pain or in progression of deformity. Detailed operative approaches will be discussed later this day. Complete or incomplete paraplegia means a rapid decompression of the spinal cord. The stabilization of spine fractures could be done either from dorsal or ventral or dorsal and ventral in addition. With the assistance of the load-sharing classification, one can estimate the need for a secondary ventral stabilization after completion of imaging. The model classification fails to assess the ability of the injured spine to withstand compressive load and cannot predict instrumentation failure. The load-sharing classification depends on the degree of comminution and the position of bone fragments. The point system was developed in 1994 by McCormick and grades the extent of the vertebral body comminution, the amount of fracture displacement, and the amount of correction of kyphoid deformity. For each category, a maximum of 3 points can be given. Fracture and mild comminution, totaling 5 points or less, can be successfully repaired from the posterior approach with the digger screw implants. Severely comminuted fractures scoring 6 points or more must be repaired by an anterior approach with vertebrectomy and strap grafting. However, in many cases, other violations of the patient will determine further therapy. 50% of patients with spine fractures have associated injuries like craniocerebral trauma, chest trauma, multiple trauma, or discontinuous vertebral fractures. For example, the opposite spine. In geriatric patients, the therapeutic options often limited by chronic diseases, osteoporosis, or poor general condition. Conclusion. The classification of spine fractures to determine stability is a key element in this decision making, but the determining factor is always the overall patient. Thank you.
Thank you very much for this clear